Thank you. As you can see, we have quite an exciting program for you this morning, and we're going to move straight into our first talk, which will be delivered by Dr. Shireesha Dhanireddy. Shireesha is a professor of medicine at the University of Washington and the director of the Harborview Infectious Disease Clinic and the Madison Clinic, both of which are key clinics in the infectious disease program there. The Madison Clinic is the largest primary care HIV clinic in the Pacific Northwest. Dr. Dhanireddy is a clinician who sees patients at both of these clinics, and she's also the co-founder of SHE, or SHE, Safety, Healthy, and Empowered Clinic, which is a low-barrier primary care clinic for women engaged in street-based survival sex. She is a board-certified physician in infectious diseases, internal medicine, and addiction medicine, and she's also one of our co-chairs for the NIH CDC IDSA Opportunistic Infections Guidelines panel, and she's going to start us off with an introductory talk on past, present, what's new, and a review of the guidelines. So I'll turn it over to you, Dr. Dhanireddy.
Thank you so much, Connie, for that introduction, and thank you for inviting me to this important panel based on the results of that survey that Roger reviewed, Dr. Padima reviewed. And I kind of wanted to go through how we got here, and by going through a little bit of history of where we were. And so as I mentioned, no disclosures here. What I'd like to go through is describe some trends in HIV and opportunistic infections, and then go through some resources for prevention and management. My colleagues who are going to be following are going to be focusing on specific OIs to review management, diagnosis, and management of those. And I'm doing a little bit more of an overview and to familiarize yourself with some resources. Not that you have to know all of this information about these infections right off the tip of your tongue, but places where you can look to really find out the data. So where we were, the first documented cases of OIs that were recognized in the US was really in the early 80s. In Los Angeles, there were a cluster of cases of pneumocystis. And prior to that, people had really not seen this infection. And there were, as we know, over the coming decade, there were many people diagnosed with pneumocystis pneumonia. And many providers at that time are similar to what we have now, not really sure about the management, not seeing these cases very often prior to this. As we know, there was more than just KS. There was a cluster, of PJP. There was also clusters of Kaposi sarcoma, which is HHV8 or human herpes virus 8 mediated. And that was also extremely rare prior to HIV and AIDS. We know that in the decade that followed these early reports of these opportunistic infections, there was a lot of work going into identification of HIV and then the introduction of highly active antiretroviral therapy, which we don't even use that term anymore because everything we use for HIV management is highly active at this time. But that was such a new concept, given that we didn't have a lot of medications in the 80s and early 90s. And in the mid 90s, there was a revolution in the way we treated HIV that led to dramatic changes in morbidity and mortality of people living with HIV. So what we saw after the advent of ART, effective ART, is a substantial decline in opportunistic infections. I will note that there's an asterisk, and I'll get back to that. But right around the time that a highly active antiretroviral therapy was introduced, up to 40% of people with HIV had disseminated MAC, and almost as many also had diagnosis of PJP as well. And so it was very common in people with HIV. And as you can see over the decade, over the 2000s, that there was a dramatic decline. And these are based on studies now that are a bit old, I will say the last one was in 2016. And we do know that reporting for OIs is considerably different. And so there's likely an underreporting of cases that as we see people with HIV that now that we may not report cases of MAC and we may not report cases of PJP. So this data may be a little bit misleading as to how much OIs we're actually seeing. One of the things that make us think that is that there's still people in our cascade of care that are still lacking for resources or have barriers and challenges to maintaining being maintained in care and on antiretroviral therapy. This is the cascade of care, or the care continuum for HIV, and this was last updated a few years ago. And you can see that about 87% of people with HIV are thought to be diagnosed with HIV. So that leaves some that are not yet diagnosed. And those are the people that we worry about, that present late, that present with possible opportunistic infections as their presenting symptom for HIV. And then we know that there's a drop-off in terms of diagnosis to receipt of care and retention in care and virologic suppression. And all of these areas are areas of focus that we need to work on to not only diagnose people, but to maintain them in care and support adherence and address those challenges. So what about late diagnoses? So late diagnoses, the definition has changed a little bit over time, but really what it is that it's a stage 3 diagnosis. So either having an opportunistic infection within 3 months, or a presentation of your HIV diagnosis, or a CD4 count less than 250. And so I thought this was really interesting. This is a study that was published looking at where we were seeing late diagnoses. And you can see that overall late diagnoses were really declining, except that green line, which represents non-metropolitan areas. And so why would that be? Why would living in a rural community? I think there's a couple of factors that contribute to that. So those of you who are working in more rural communities, there could be stigma about even going in for diagnosis or maintaining care in HIV in such a small community. And there could also be a lack of recognition of risk of getting HIV, or education about importance of screening for HIV in those communities, not just from patients and individuals living in those communities, but perhaps providers as well, with a potential bias for who might be the ones getting HIV. And it may not be what we think of classically, and who was originally in the 80s diagnosed with HIV, which was predominantly MSM. Drug use has been a big contributing factor, and I'll show you the next slide about kind of our eye-opening wake-up call about that, as well as older age people that there may be a bias about whether there is sexual risk or risk in older populations, and maybe less screening, maybe stigma that is leading to that as well. So under recognition of risk, I think both on the provider and the individual at risk is a big thing that we need to confront in the medical community. And one of the big eye-opening things that I mentioned here is the huge wake-up call from the outbreak in Indiana. So HIV linked to injection drug use in these rural communities in Indiana about a decade ago. And these were individuals who were using drugs and had shared networks. And there was a cluster of cases. There were a number of HIV cases, but also even more hepatitis C cases from this outbreak. And you can see that the initial diagnosis was in November of 2014, and that cluster was identified a few months later. And then there was a lot of work from the public health standpoint and CDC standpoint to really address this by offering prevention measures and risk reduction measures in these communities. particularly in the form of syringe exchange. But a public health emergency had to be declared to get some of these resources. And you can imagine that there's a lot of these communities that we may not identify these clusters, and people may present late into care. The other issue is that disparities continue to exist. And so you can see here the age-adjusted rates for death in people with HIV. And you can see where I am in the Pacific Northwest is actually much lower rates of death than what we see in the South and Southeast, which is really disproportionately affected in terms of death rates. And then one other thing is that you can see that there is a lot of disparity in terms of race. And a lot of the death rate disparities in the Southeast are due to higher proportions of Black and African American individuals who have higher death rates from HIV, as well as a lot of other things that you can see in terms of the spectrum of reasons for death, like unintentional injury. COVID is a big one in the last few years, obviously, but you can see compared to whites that HIV is considerably higher in terms of a risk factor for death or cause of death in people with HIV. So what are our strategies and tools to get a better outcome? I think this is beyond the scope of this talk, but I think it does affect our impact on seeing these OIs. If we can get people into care earlier, and obviously HIV prevention is a huge tool that we have that can prevent people from getting HIV so they don't have to get these OIs. A routine HIV screening over the last few decades, we've really tried to standardize HIV screening rather than an opt-in approach to really destigmatize testing, but there's still communities where we're not seeing as much screening as we could be. And then of course, early ART initiation is key. Even when people are presenting with late in disease, we want to get them right away on ART, and we'll talk about some caveats for that in later talks. And then promoting and engaging adherence and engagement in care are key things to do. I think the other thing that we want to focus on is what can you do if you're seeing someone late stage HIV and one of these OIs, and you've not seen one of these OIs before, and you don't know what to do? Well, there are tools. And one of the things that Connie mentioned is that we work together on the guidelines for prevention and treatment of opportunistic infections in adults and adolescents with HIV. So this is a long-standing guidelines group that I had the privilege of joining in 2015, and then more recently became co-chair. But this group had been coming up with guidelines even before it was a formal guidelines group to address how to treat MAC, how to treat PJP in these patients, because so many people were seeing these cases and didn't really know what to do. So let me explain a little bit about the process of this group and go through some of the highlights of our guidelines. So there are some co-chairs of this group that are the overarching leaders of the group. There's representation from NIH, from CDC, from HIVMA, and IDSA. And our charge is to review these guidelines, ensure they're updated. We're sort of the final review process of these guidelines. Each section or each OI has a group, and there's a subject there which consists of subject matters experts and a leader of that group that ensures that these sections are updated regularly. There's a literature review that's done quarterly, that's sent to these groups, and to ensure that any new randomized controlled trials or additional data that comes about is updated and reflected in the guidelines. And there's also a readability group. And because many of the people are scientists that are doing this work and are moving forward treatment, diagnosis of these guidelines, we want to make sure that we have clinicians that are also familiar with these diseases and are the frontline providers of these for patients with HIV, that look at it and make sure that the content is really useful and readable, and easy to look at and easy to look up. Otherwise, it's not very useful for our end user. In terms of the impact of these guidelines, you can see that there's a lot of page views, over 500,000 page views for these guidelines, and an increase from 2022. And that could reflect an increase in OIs. One of the things that we're seeing more is immigrant populations that are, I know we're seeing that in our community in Seattle, where we're seeing people present late, either diagnosed in a country from where they're immigrating, or diagnosed here late with either PJP or MAC or KS or a TB. And so clearly making an impact here. And just to break down how many page views for each section, and you can see that pneumocystis is really by far and away the most common OI that's viewed and for whatever that is, diagnosis, management, prevention, that is the most common OI, followed by Cryptococcus, which we're both going to be discussing today. And then you can see a smattering of other things, including MAC, including TB, HPV, PML, immunizations. You can see a whole host of things that people are looking up to gain knowledge about these common and not so common infections in people with HIV. In terms of who uses the guidelines, the majority is from the United States. These guidelines are more focused on US practices, but you can see that there are a number of other countries that also view these and rely on these guidelines. And so you can see that a quarter of people are accessing it from India, which I think is really interesting. So let's focus a little bit on the different opportunistic infections and ways that we can, or aspects of the guidelines that we can focus on. There's way too much to do an overview talk about everything, but I thought what I would do is hit a few of the highlights before my colleagues talk about specific OIs. So vaccines. So vaccines is an important one that I think actually has a number of page views for our guidelines. And in these guidelines, I just put some highlights in here. There's a very in-depth table that you can review. And one of the things that's important to note is that immunizations in people with HIV are different. Some of these are different guidance than they are within the general population. And that's really because of a number of factors, depending on which disease. Increased risk of more invasive disease, like with pneumococcal disease, higher incident rates, like with herpes zoster. And so we think about those, and we think about this as an area of prevention. So we're not seeing people in the hospital with these diseases. What are the things that we can do at a routine visit to keep people healthy? And so I encourage people to look at these vaccine tables when they are seeing people with HIV and note where they vary. Like I mentioned, pneumococcal disease, zoster, actually another one is meningococcal disease. And so try to keep your patients healthy. The other one that I really wanted to spend a little bit of time on is anal cancer screening guidance. I think this is an important one that is new and was just updated recently in the last couple of months based on some data from the ANCHOR study, which is a multi-site study looking at early treatment as an intervention for high-grade dysplasia in anal dysplasia in people with HIV and whether that decreased incident cancer rate or progression to cancer. And it did. As part of that, people got screened regularly every 6 months for anal dysplasia to be able to identify people who would get either treated or monitored for development of cancer. So I want to point out that that wasn't a screening study, but screening was done to identify who would get the intervention, and the intervention did have an impact. So based on that, there are now anal cancer screening guidelines for people with HIV. And the main thing to note is that all transgender women and men who have sex with men starting at the age of 35 should have anal cancer screening. What that modality of screening is based on what resources you have available, particularly if you have high-res anoscopy available in your area. If you don't, then really it's mainly an exam of visualization and or direct it's a DARE or digital anal rectal examination to feel for abnormalities and assessing symptoms. If you do have HRA available, then we do recommend cytology plus or minus HPV co-testing to further characterize and the risk for that patient. These are, since they just came out, people are really still working on how to implement these in their community, particularly those communities with lower resources for HRA or no HRA resources. I do want to put in a plug for an IAS-USA anal cancer screening webinar that's going to be happening later this month, I think actually next week. On the 19th, and it's going to be moderated by Ruann Barnabas, and the discussant and expert is Grant Ellsworth. And so I highly recommend that for anyone who is interested in learning more about anal cancer screening and how we can use that as a tool for prevention. We know that people with HIV have a much higher incident rate of anal cancer, particularly MSM and transgender women with HIV. So it's an area where we can decrease cancer rates. Okay. I know that there's going to be more discussion about some of this in the OI guidelines, but the subsequent discussions that Dr. Benson and Dr. Boulware are going to have and Dr. Armstrong as well. But I wanted to say that this is probably one of the highlights that people look at. There are a number of tables for prophylaxis for all of the OIs where you can have a quick reference for what to do. And the indication for when to start OI prophylaxis, what are the preferred treatments. Of course, there's a larger narrative section where you can really dig deep and learn about the data that led to this. But if you want something quick and easy when you're seeing a patient who comes to you with a low CD4 count and you're not sure what to do, these are the tables to refer to. And I think this is, if you're going to use anything, this is probably one of the main things to focus on. And then importantly, discontinuation of prophylaxis. So one of the things that we worry about is when are people ready to stop using their prophylaxis? When do we feel like their immune system is reconstituted enough where we would stop these antibiotics or medications for prevention? And there's tables for that too, in terms of all the diseases that require prophylaxis. I just put the two highlights here of MAC and pneumocystis, but there is there's a long table that you can review to go into more detail. So what does the future hold? I think we've made some significant advancements in disease preventions, and we have the tools to prevent and treat these OIs. And we have the resources for providers to be able to quickly navigate to how to address these OIs. But I think the bigger issue here is that there's still these ongoing disparities that lead to delays in testing, delays in or barriers to retention and care, and that we really have to address these social determinants of health to eliminate AIDS or end the HIV epidemic. The following speakers are going to focus on some of these OIs that they're seeing in their communities still, and these late presentations, and give you some tools about how to identify and address these OIs in more detail. I'd be happy to take any questions.
Well, thank you, Dr. Dhanireddy. That was a spectacular overview for the rest of the program today. And thank you for introducing the topic so succinctly for our audience. As you know, we would like to have all of your questions listed in the Q&A. There are a number of comments in the chat, which we do appreciate, and mostly thanking you for the great overview, Dr. Dhanireddy. But if you have specific questions on this topic, please include those in the Q&A. And while we're waiting for the rest of our audience to add questions, let me just start with some that came in before the program. I may adapt a few of these to be more focused on your particular topic. There is one, I think, really nice comment in the pre-program questions that indicates mostly I just feel lost when it comes to OIs. And I think that's part of the genesis for us to include this symposium for people who are seeing patients with HIV infection. So one of the things that I think you did focus on in your discussion, Dr. Dhanireddy, is that the US NIH CDC IDSA guidelines are primarily focused on treatment and prevention for OIs in higher resource settings in the US and maybe North America and Europe, but also to understand that there are guidelines that have been prepared for opportunistic infections by the WHO as well. And one question that came in from the audience is, how do you adapt management to resource limited settings from the guidelines that we provide you here?
Yeah, I think that's a great question, and actually something that we've actually talked about in the OI guidelines group, because some areas within our own country are actually relatively resource poor compared to other areas. And then these social determinants lead to also disparities in access to care that don't make it a uniform playing field for some of our patients, even within our own country. But there are in the OI guidelines, there are mention of data from less resource rich settings that actually are primarily where we get the data from, because for TB, for instance, a lot of that data comes not from the US to help guide our practice. And so we do have acknowledgement of that data and what people are doing. One example that I don't want to steal anyone's thunder, but there are data for doing a single dose info, for instance, for cryptococcal disease. And so how do we address that in a place where we are able to do the preferred therapy of the 2 weeks induction in people with disseminated disease? And how do we incorporate those data into our practices? And are those data sufficient to allow for single use, which has been noted by the WHO? And so I think there in our guidelines, there is an acknowledgement of that data and that guidance for other resourced areas, but we continue to focus on our country, our what we have in terms of resource-rich setting. There was a question about toxoprophylaxis. There are some questions in the Q&A. Do you want me to do those, Connie?
No, I'll send you the
Okay.
question. So yes, we do have a couple questions that came in through the Q&A. Let's just finish off one more thing from the questions that came in earlier. And I think many of the questions that came into us early are ones that will be addressed by some of the speakers. So I'm not going to touch on those, but I will. But if they don't come up in those discussions, we will answer them in the Q&A thereafter. So I think there has been, you touched on a comment related to our new guidelines for HPV. So one of the comments in the Q&A is HPV vaccination in younger patients living with HIV for men and women, and would like you to just comment briefly on your recommendations for HPV vaccine.
Yeah, HPV vaccine is a great tool for prevention of cancer, warts in people with HIV. And I think the main thing to note that is different from the general guidance is that we still recommend 3 doses of vaccine rather than the accelerated 2-dose or the shortened 2-dose schedule that is recommended for the general population if you're 15 and younger. So for individuals with HIV, it's 3 doses of HPV vaccine. And it's similar to the general population in that it's the guidance is to vaccinate at age 11, but 9 through 26. And then from 26 to 40, age 26, after age 26 to 45, it's a shared decision making based on risk. And that's sometimes hard to figure out how to determine when it's a shared decision making. But what I tend to do in practice is determine if they're in a mutually monogamous relationship and don't anticipate future sex partners, then they probably don't need the vaccine. However, if they have frequently new sex partners, then I would consider offering the vaccine to them and have a discussion about that.
And a related question is that increasing numbers of our patients are young enough to have received HPV vaccines in the 90s. Does a history of the vaccine series impact the screening algorithm?
It does. I think it would impact it. So we are preferring that patients in our setting wait until they're a little older to get anal cancer screening, only because we don't have the resources in our setting. And the cancer rates in the anchor study were really in older individuals, 50 or over. And so anytime we start a screening program, we start earlier than that. Many of the patients that we're seeing haven't had vaccination at all for HPV. But as we follow this along, I think we're going to see the impact. If you're going to do anal cancer screening with HPV co-testing, for instance, the highest risk is 16 and 18, particularly 16, type 16. And the vaccine includes that type. Of course, there are other types of HPV that can lead to cancer. And so I really, we do want to make sure that we still follow along. I think we're going to have more epidemiologic data and more data that comes along. Even since the publishing of the anchor study, we have additional data that is impacting likely our screening algorithms in the next year or 2.
Well, there's a lot of interest in HPV here, Shireesha. So
yes, we don't really have the quadrivalent type of a vaccine made anymore in the United States. We only have the nonavalent vaccine. And so that's what everybody should be using at this point.
So in the Q&A, there's several questions related to MAC, which we will get to during the MAC lecture. So I'm going to put off answering those. Let's go back to the toxo question. Now, there will be a treatment case for cerebral toxo, I believe, in our panel discussion. So I might defer the treatment questions to that component of the program. But one question about toxo in the Q&A is, do you still consider toxo prophylaxis for people with HIV?
I do, particularly with, it's really indicated for people with a CD4 count less than 100. But for most people, when they're less than 200, when we're doing PJP prophylaxis, we cover toxo prophylaxis because trimethoprim sulfamethoxazole is the preferred prevention for both PJP and toxo. For those who are sulfa allergic and really sulfa allergic, and they're below 100, then we have to think about pyrimethamine as the prevention. But our goal is to get people on ART as soon as possible and get those CD4 counts up. So if patients are reluctant to start additional meds, I really prefer just pushing the ART and get their CD4 counts up over prophylaxis. And we know that with MAC, that is the preference, to just get people on ART.
Great. Let me go back to there was one question which we're not going to be covering in the program. So you or I can address the question, but it asks about whether the guidelines or what are the guidelines for newer short course regimens for TB prophylaxis. And if you'd like, I can take that. I'm one of the co-chairs of the TB section for the OI guidelines, but so Dr. Dhanireddy very nicely outlined the resources available to you for updated guidelines for all of the opportunistic infections. And there's a very extensive chapter in those guidelines that you can review online for all of the information related to tuberculosis. I might also add that IAS-USA is planning a webinar later in the fall that will be solely focused on TB and will cover the data related to short course regimens for TB prophylaxis. But as you might imagine, there are 4 different short or ultra short courses for TB prophylaxis that are now recommended in the OI guidelines. And each of them has certain caveats about their use. So it's a little bit more complex than we might want to get into today, but thank you all for that question. So I think we are nearing the end of our written Q&A. If any of you have additional questions that you'd like to bring up to Dr. Dhanireddy, please let us know in the Q&A. We can come back to her. She'll still be around on the program for the panel, so we can come back to additional questions at that time. We're a little bit ahead of time, but that's good because it gives us some cushion for the other speakers. I'm going to turn the program over now to my co-chair, Dr. Badimo, and he's going to introduce you to our next speaker, who will be talking to us about pneumocystis pneumonia.